There is a particular kind of stillness that belongs to a village at night in the middle of winter, far from any town, far from any road with traffic on it. The fire in the center of the room is burned down to coals. The animals in the byre next door shift and breathe, and their warmth comes through the shared wall in a way that is not nothing. Outside, the cold is complete and absolute. A woman in that room, lying awake in the dark, is listening to the breathing of several people around her. One of the children has been coughing for 3 days. The cough has a particular quality to it that she has heard before and does not entirely like. In the morning, she will do something about it. She knows what to do because her mother knew what to do, and her mother's mother before that, and the knowing has come down through all those women in the same way that the seeds for the garden and the words for the prayers have come down through the hands and the memory without anything written. This is where the story of medieval health begins. Not in a physician's consulting room, not in a monastery, library full of herbals, but in a low house in a village that has no name in any surviving record, where a woman with practical knowledge and limited resources is making the same calculations that people have always made. When someone they care for is sick and the options are constrained, what do I have? What do I know? What can be done? The answer to that last question across the medieval centuries in rural Europe was more than is sometimes assumed, and less than was needed. The gap between those two things shaped daily life in ways that are worth understanding carefully, because the picture that emerges is not simply one of helplessness and ignorance, but of a complex, practical, imperfect system of knowledge and response that kept populations alive through conditions that modern medicine would find challenging. The baseline of health in a medieval peasant community needs to be established before the question of what they did when things went wrong can be properly addressed. The baseline was difficult. Life expectancy at birth in medieval England and Europe generally, based on the available skeletal and documentary evidence, was somewhere between 30 and 40 years. This number is heavily influenced by high child mortality, particularly in the first 5 years of life, and does not mean that most people died in their 30s. A person who survived to adulthood had a reasonable chance of living into their 50s or 60s, but the path to adulthood was genuinely dangerous, and many did not make it. The causes of that mortality were concentrated in a few areas. Infectious disease was the largest single category. Respiratory infections, including what we would now call pneumonia and influenza and various other conditions affecting the lungs and airways, killed people who had been weakened by cold, by poor nutrition, or by prior illness. Gastrointestinal infections transmitted through contaminated food and water killed both the very young and the very old with particular efficiency. Wound infections, which would be trivially manageable with modern antibiotics, could follow any cut, scrape, or injury deep enough to allow bacteria to establish themselves in tissue. Childbirth killed women at rates that are difficult to establish with precision, but were certainly high by modern standards, with estimates ranging from perhaps 1 in 50 births resulting in maternal death to considerably higher in some communities and some periods. A woman who survived her first delivery and her first postpartum weeks had demonstrated some degree of resilience, but the risk was present with every subsequent pregnancy, and a woman who bore 6 or 8 children over her adult life was taking that risk repeatedly. Malnutrition, not starvation, but the chronic insufficiency of specific nutrients was widespread and had effects on immune function, wound healing, bone density, dental health, and overall physical resilience that compounded the risks from infectious disease. A population that was marginally undernourished for most of its life was a population whose capacity to fight off infection and recover from injury was systematically reduced. The village itself was the primary unit of social organization for most medieval peasants, and the village was also the primary unit of health management. There were no hospitals in the modern sense available to rural people. There were no trained physicians within any reasonable distance of most villages. The physicians who did exist in medieval Europe were concentrated in towns and cities, were expensive, and operated primarily from a theoretical framework derived from ancient Greek medicine that, while not without some practical content, was more concerned with balancing bodily humors than with the kind of empirical observation of disease that would eventually produce effective treatment. What the village had instead was a combination of things that, taken together, constituted a health system. In a loose sense, it had accumulated practical knowledge about local plants and their uses passed down through generations of people who had tried things and observed results. It had social networks of mutual support that meant sick people were not entirely alone in their illness. It had various practitioners, some more formal than others, who provided services ranging from midwifery to bone setting to the preparation of remedies, and it had a framework of belief, religious and otherwise, that provided psychological support and a sense of agency in situations where the material options were limited. None of these things individually were sufficient. Together, they represented a practical system for dealing with illness and injury that was the product of centuries of trial, error, and the accumulation of whatever worked well. Enough to be worth remembering, the herb garden attached to a peasant household where one existed was a working medical facility in a way. That is easy to underestimate. The plants grown there were not grown primarily for culinary interest, though. Many were also used in cooking, but for therapeutic purposes that had been established through long observation and passed down with specific instructions about preparation and use. Some of these plants had genuine pharmacological activity that is now understood in terms of the chemical compounds they contain. Willow bark, which was used for pain and fever reduction, contains salicin, a compound that the body metabolizes into salicylic acid, which is chemically related to aspirin. Feverfew was used for headaches and fevers. Valerian root was used to promote sleep. Elderberry preparations were used for respiratory infections. Garlic was used for infections and was applied externally to wounds. St. John's wort was used for a range of conditions, including what we might now recognize as depression. Plantain leaves, which grew as weeds in every disturbed soil, were used to draw out infection and reduce inflammation in wounds. The effectiveness of these remedies varied enormously. Some had real effects on the conditions they were used for. Some had effects on symptoms without addressing underlying causes. Some were entirely ineffective against the specific disease but harmless and provided the psychological benefit of doing something. Some were harmful, particularly in excessive doses, and the folk knowledge around preparation included warnings about quantities that were passed on with as much care as the recipes themselves. The transmission of this knowledge was primarily through women, though men with specific roles such as the local herbalist or wise man were also repositories of plant knowledge in many communities. The woman who managed a household managed the household's health as a central part of that role and the knowledge required. For that management was accumulated over a lifetime and passed to daughters and other younger women in the community. This was not a formal training process, but a continuous apprenticeship embedded in daily life in which younger women assisted with the care of sick people under the direction of more experienced ones and gradually absorbed both the practical techniques and the conceptual framework that organized them. The preparation of remedies from plants required knowledge of when to harvest, which part of the plant to use, how to prepare it, and what dose to apply. These variables matter because they determine whether a plant produces a therapeutic effect or no effect or a harmful one, and the traditional knowledge that governed them was not arbitrary. It was the residue of many generations of observation about what happened when things were done in particular ways. Harvesting time mattered because the concentration of active compounds in many plants varies considerably, depending on the time of year, the stage of the plant's growth cycle, and the specific conditions in which it grew. The traditional instruction to harvest particular plants at particular times of year, which appears in various medieval herbal texts and which presumably reflects oral knowledge predating those texts, turns out in many cases to align with the times when the relevant compounds are present in highest concentration. The part of the plant mattered similarly. Roots, bark, leaves, flowers, seeds, and berries often contain quite different chemical profiles even from the same plant, and traditional knowledge about which part to use for which purpose reflects accumulated observation about differential effectiveness. The instructions that survived were the ones that produced results reliable enough to be remembered and passed on. Preparation methods included drying, which preserved plant material for use through the winter and concentrated some compounds while destroying others. Infusions in hot water extracted water-soluble compounds. Maceration in oil or fat extracted fat-soluble compounds and produced preparations suitable for external application. Fermentation produced alcohol-based extracts that remained stable for longer periods than water-based ones. Dosage was managed through the traditional measures embedded in recipes, which were often described in terms of quantities that related to the preparing person's own body, such as much as you can pick up between thumb and finger, or a handful. These measures were imprecise by any quantitative standard, but they provided a consistent reference within a community where the people using them were familiar with each other and with the results of previous preparations. Wounds and injuries were among the most common health problems in agricultural communities, where people worked daily with sharp tools, heavy loads, and large animals. A cut from a scythe, a crush injury from a fallen cartwheel, a bite from a pig, a burn from the hearth fire, a fracture from a fall from a tree or a barn roof. These were the ordinary hazards of a working life, and the responses to them were based on knowledge and materials that were immediately at hand. Wound cleaning was understood, even without knowledge of the microbial causes of infection to be necessary. The traditional practice of cleaning wounds with clean water with urine, which is normally sterile and was available in a way that specially prepared antiseptic solutions were not, or with vinegar or wine, which have genuine antimicrobial properties due to their acidity, reduced infection rates compared to leaving wounds dirty. This was empirical knowledge, the result of observing that wounds treated in certain ways healed better than those treated in other ways without understanding why. Wound dressings made from plant materials included applications of honey, which has genuine antibacterial properties related to its high sugar content, low moisture, and the presence of hydrogen peroxide producing compounds. The use of honey on wounds is documented across many cultures and time periods, and its effectiveness was not simply tradition but the result of observable outcomes. Wounds dressed with honey did, on average, become infected less often and heal more cleanly than wounds left undressed, and this was observable by anyone who paid attention. Plantain leaves applied to wounds provided a cool, moist surface that reduced inflammation and had some antibacterial properties. Comfrey, whose Latin name symphytum relates to its reputation for helping tissues grow together, was used extensively for both external wounds and fractures. The compound allantoin, found in comfrey root and leaves, has been shown in modern research to promote cell proliferation, which is consistent with the traditional use. It was also applied as a poultice to bruises and sprains. Wounds that became infected despite these measures presented a more serious problem. The signs of serious wound infection, the spreading redness, the heat, the swelling, the fever, the characteristic smell of suppurating tissue, were well recognized and associated with bad outcomes. The treatments available, increasing the drainage of the wound, applying preparations designed to draw out or kill the infectious material, and in extreme cases cutting away dead tissue, were crude but not entirely without effect. The primary limitation was the absence of any agent capable of killing bacteria systemically, which meant that an infection that spread beyond the wound itself into the bloodstream was very difficult to treat. Bone fractures, which happen regularly in communities doing heavy physical labor, were managed with a degree of skill that the archaeological record confirms was sometimes quite effective. The evidence comes from skeletal remains that show healed fractures, and while many of these show malalignment that would have produced some degree of permanent functional limitation, others show healing that is quite close to what might be expected after modern treatment. The basic principles of fracture management, immobilization of the broken bone in a position as close to normal anatomy as possible and maintained through the period of healing, were understood and applied. Splints were made from whatever rigid material was available, including wood, bark, and in some cases materials that were first softened and then dried in place to conform to the limb's shape. The splint was bound with cloth or leather, and the limb was rested as much as the patient's obligations allowed, setting a fractured bone before immobilizing it, which is necessary when the fragments have displaced significantly from their normal positions, required both knowledge of normal anatomy and practical skill in manipulation. Bone setters, people with particular reputations for this skill, existed in most communities and were called upon when the standard household knowledge was insufficient. The bone setter's reputation was based on observed outcomes, which meant that individuals whose skill was good maintained practices, while those whose manipulations consistently produced poor results were bypassed in favor of others. The healing of a properly set and immobilized fracture was a biological process that the medieval treatment either facilitated or impeded, but could not directly accelerate. Adequate nutrition, particularly calcium and vitamin D, affected the rate and quality of bone healing in ways that were not understood in those terms, but whose effects on outcomes were observable. People who healed well from fractures probably tended to be those who were better nourished, and the variability in healing outcomes across individuals would have reinforced the sense that some people were simply more resilient than others. The relationship between nutrition and health was understood empirically in medieval communities without the conceptual framework of vitamins and minerals that would eventually explain the mechanisms. The observations that certain foods helped sick people recover, that certain dietary patterns were associated with specific diseases, and that seasonal variation in diet correlated with seasonal variation in health, were all part of the practical knowledge base of communities that paid close attention to the connections between what people ate and how they fared. Scurvy, caused by vitamin C deficiency, appeared in communities that had limited access to fresh vegetables and fruit over extended periods, typically in late winter and early spring before the first fresh produce was available. The symptoms: bleeding gums, loose teeth, bruising that appeared without injury, reopening of old wounds, and general weakness were recognized as a condition with a season and with remedies that included fresh greens and certain preserved preparations. The first fresh nettles and sorrel of spring, gathered from the margins of fields and waterways, were valued partly for this reason, and their use as a spring tonic is documented across many medieval European communities. The tonic theory was not biochemically precise, but the observation that spring greens made people feel better after a winter of limited fresh food was accurate. Rickets, caused by vitamin D and calcium deficiency, was a condition of children raised in low light environments without adequate dairy or fish in the diet, and it produced the characteristic bowed legs and soft bones that are visible in some skeletal remains from medieval populations. The connection between sunlight and bone health was not established until the 20th century, but the observation that children who spent time outdoors tended to be healthier in various ways was available to anyone who looked. Iron deficiency anemia, common in women of reproductive age, particularly in communities with limited access to meat, would have produced the pallor, fatigue, and reduced physical capacity that were probably interpreted as general weakness or wasting rather than a specific nutritional deficiency. The traditional advice to women to eat liver and dark greens, both of which are rich in iron, may reflect accumulated observation, even if the rationale was not understood in those terms. The management of fever was one of the most common therapeutic challenges in any medieval community, because fever accompanies a wide range of infections and was both uncomfortable and, in severe cases, threatening to life. The responses to fever that are documented in various medieval sources and that almost certainly reflect much older oral traditions covered a range of approaches. Cooling measures, including the application of cold water to the patient's head and body, the use of cool compresses, and the provision of cool drinks, addressed the temperature directly and provided symptomatic relief regardless of the underlying cause. The instruction to give a feverish person small amounts of cool liquid frequently also addressed the risk of dehydration that accompanies sustained fever, a practical benefit even, without specific knowledge of fluid and electrolyte physiology. The use of willow bark preparations for fever reduction, already mentioned in the context of pain management, provided a genuine pharmacological intervention. The salicylate compounds in willow bark reduce fever through the same mechanism as aspirin, inhibiting the prostaglandins that mediate the fever response. A preparation of willow bark tea given to a feverish person had real effects on the fever, and the observation of those effects reinforced the use of the remedy across generations. Elderflower preparations were also used for fevers, and elderflower does contain compounds with genuine antipyretic and diaphoretic properties, meaning they promote sweating, which is the body's own mechanism for reducing temperature. The tradition of giving feverish patients hot herb teas to bring on a sweat reflects an understanding of this mechanism that was empirical rather than theoretical. The rest and warmth provided to feverish patients, which is the instruction most consistently associated with fever management across traditions, also has genuine therapeutic value. Rest conserves energy that the immune system requires for its responses to infection. Warmth reduces the metabolic cost of maintaining body temperature when the patient is already working hard immunologically. The midwife was one of the most important practitioners in any medieval community, and her role extended considerably beyond the management of childbirth itself. She was involved in prenatal care, in the assessment of difficult pregnancies, in the delivery itself and the management of its complications, in newborn care, in the hours and days after birth, and in the postpartum recovery of the mother. She also had knowledge of the herbs and preparations associated with reproductive health, menstrual regulation, and fertility, and this knowledge positioned her as a specialist in a domain of female health that was largely outside the concern of male medical practitioners. The midwife skills were acquired through apprenticeship, typically assisting an established midwife over many years before taking primary responsibility for deliveries. The experience accumulated through this Apprenticeship was both practical and interpersonal because managing childbirth required not only technical knowledge, but the ability to support a laboring woman through a process that was long, painful, and potentially dangerous, without access to the pharmacological and surgical interventions that now make that support easier. To provide the complications of childbirth that a medieval midwife encountered and had to manage with available means included prolonged or obstructed labor, postpartum hemorrhage, placental complications, infant presentations, other than the normal head-first position, and infections of the birth canal and uterus in the days following delivery. Her tools were her hands, her knowledge of herbal preparations, her experience with the range of variation in normal and complicated labor, and her ability to make decisions under pressure with limited information. Some of these complications were beyond her capacity to resolve successfully regardless of skill. An obstructed labor where the infant was too large or positioned in a way that made vaginal delivery impossible was a situation without a good solution, since cesarean section as a survival procedure for the mother was not practically available. Severe postpartum hemorrhage could kill a woman faster than any available intervention could stop the bleeding. But many complications that looked serious were ones that experience and practical skill could address, and a midwife who had attended many deliveries had a body of experience that was genuinely valuable. The recovery period after illness was understood to require particular care and was managed with specific foods and practices. Convalescent diet in medieval communities typically emphasized foods that were easy to digest, warming, and nutritionally dense. Broths made from bones and scraps of meat, long simmered to extract whatever nutrients the bones contained, were given to people recovering from illness. Gruel made from oats or barley provided easily digestible carbohydrate. Honey, eggs where available, and soft-cooked vegetables were the components of a diet designed to support recovery without overtaxing a digestive system that had been weakened by illness. The bone broth tradition is one of those traditional practices whose value is difficult to assess precisely, but which is certainly not entirely without basis. Long-simmered bones release gelatin, some minerals, and various other compounds into the broth, and while the specific therapeutic claims sometimes made for bone broth in popular discourse exceed the evidence, a warm, easily digestible, mineral-rich liquid provided to someone recovering from illness and likely in a state of mild dehydration and nutritional deficiency was not without value. Rest was also managed as a therapeutic intervention rather than simply the absence of activity. The instruction to rest, to sleep, to avoid cold and exertion, to stay near the fire, and to allow the body time to recover was embedded in the practical care of sick people and reflects an understanding of recovery as an active biological process that required resource allocation, specifically the redirection of the body's energy from work to healing. This understanding was not articulated in physiological terms, but it was functionally correct. The social support that surrounded illness was part of what made this rest possible. In a community where everyone's labor was essential to collective survival, a sick person who needed to rest while others did extra work was creating a burden that the community absorbed because it understood from direct experience that the burden of not supporting recovery was greater, a person who died or who remained chronically ill from inadequate care during recovery was a permanent loss. A person who recovered fully and returned to productive work was an investment that paid off. The village wise woman, or cunning woman as she was known in some English traditions, occupied a role that overlapped with but extended beyond the midwife's. She was the person consulted for both physical and what we might now call psychological or social problems. And the distinction between those categories was not rigidly maintained in medieval thinking in the way it is in modern medicine. She knew plants and their uses. She knew the specific remedies associated with specific conditions in her community's tradition. She had experience with a wide range of health situations because she was the person called upon when things were difficult. She also occupied a more ambiguous social position than the midwife, whose role was well defined and broadly respected. The wise woman's knowledge of plants that had effects on reproduction and psychological states, and her role in situations that had no clear natural explanation placed her on the boundary between the acceptable and the suspicious in the view of the church and of authorities. The long history of persecution of women who practiced folk medicine under accusations of witchcraft is a complex subject that intersects in complicated ways with the history of folk healing, but it shaped the social position of practitioners and affected the transmission of their knowledge in ways that are difficult to trace but certainly real. Despite this ambiguity, the services of the wise woman were sought and valued because the alternative, having no recourse at all to specialist knowledge when illness struck, was worse. The practical community maintained a working relationship with these practitioners even when the formal religious and legal positions were hostile, because people needed what she knew and were willing to navigate the social complexity to access it. The role of prayer and religious observance in medieval health management is sometimes treated as pure superstition in retrospect. But this framing misses something important about how it functioned in practice. For medieval peasants, the religious framework within which they understood illness and recovery was not separate from their health management, but integrated with it in ways that had both psychological and practical dimensions. The psychological dimension is significant. People who believe they are receiving care and that their recovery is supported by forces beyond their immediate circumstances show better recovery outcomes than those who believe themselves abandoned. The modern understanding of what is sometimes called the placebo effect in clinical research, and more broadly the role of psychological state in immune function and recovery, provides a mechanism for what medieval religious practice was observing. Prayer, the lighting of candles, the recitation of specific texts or formulas over a sick person, the invocation of particular saints associated with particular diseases were all practices that signaled to the sick person and to their community that something was being done, that care was present, and that recovery was possible. The saints associated with specific diseases represent a taxonomy of illness that is interesting in its own right. Saint Blaise was associated with throat conditions, Saint Lucy with eye conditions, Saint Roche with plague. The assignment of particular saints to particular conditions created a navigable system within which people could address specific problems with specific resources, and the focus that this provided was not without psychological benefit. The pilgrimage to a healing shrine, which was a significant feature of medieval religious life and which drew people from considerable distances when the local options had been exhausted, was both a religious observance and, in some cases, a practical measure, because the journey itself, the physical movement and the change of environment, sometimes produced improvements that staying in the original sick environment did not. Water from healing springs at shrine sites often had specific mineral content that could have therapeutic effects in certain conditions, and the rest and regular meals that pilgrimage sites sometimes provided were genuine supplements to the pilgrim's usual circumstances. The monastery was the closest thing to a hospital available to most medieval people, and its role in healthcare deserves particular attention. Monastic communities were required by their rules to care for the sick, both within their own communities and for travelers and poor people who presented themselves at the gates. The infirmary was a standard feature of a properly established monastery, and it provided a level of care that was, in terms of cleanliness, regularity of attention, and access to a wider range of remedies than most households could provide, probably the best available option for serious illness in most of medieval Europe. The monastic infirmarian, the monk or nun responsible for the care of the sick, typically had access to a physic garden that grew a wide range of medicinal plants, to texts that described their uses, and to a tradition of training within the community that preserved accumulated knowledge across generations. The monastic medical tradition was more text-based than the folk tradition, drawing on translations of ancient Greek and Arabic medical texts, as well as on accumulated practical experience, and it was more formally organized in the sense that it was written down and could be transmitted and consulted in ways that purely oral knowledge could not. The care provided in monastic infirmaries included nursing in a basic sense, that is, the consistent attentive presence of someone responsible for monitoring the sick person's condition and responding to changes. This consistent presence was itself therapeutically valuable in ways that went beyond any specific intervention. A person who was regularly checked on, whose food and drink were managed, whose position was adjusted, and whose progress was monitored was receiving a quality of care that made early recognition of deterioration and early response possible. The infirmary also provided something that most domestic sick rooms did not: isolation from the rest of the community. For infectious illnesses, this separation reduced transmission, not because medieval medicine understood contagion in the modern sense, but because experience had established that sick people should be separated from well people, and the infirmary structure made this separation practical. The management of infectious disease in a community without understanding of germ theory was necessarily empirical, based on observations about patterns of spread rather than on knowledge of mechanisms. The observation that certain diseases spread within households and then from household to household, that people who had survived a disease did not generally get it again, that certain diseases appeared seasonally or in association with particular conditions, and that removing the sick from contact with the well reduced the spread of some conditions were all available to communities that paid attention. Quarantine, the practice of isolating the sick and those who'd been exposed to disease, appears in medieval practice in connection with leprosy and later with plague. The leprosy provisions, which required people identified as lepers to announce their presence, wear specific garments, and avoid certain public spaces and contacts, were a combination of social marginalization and disease control that reflected both the feared appearance of the disease and the practical understanding that separation reduced spread. Whether the conditions diagnosed as leprosy in medieval Europe always corresponded to what we now call Hansen's disease is a separate question, but the principle of separating people with visible skin conditions from the general population had some basis in disease prevention logic. The plague responses of the later medieval period, particularly after the Black Death arrived in Europe in 1347 and 1348, were more elaborate and somewhat more systematic. Port cities in Italy began to require ships from suspected plague-affected areas to wait at anchor before their passengers and goods could come ashore, a practice that became formalized as quarantine, from the Italian word for 40 days. The effectiveness of these measures against bubonic plague, which is transmitted primarily by fleas rather than by direct human contact, was limited in ways that could not be understood without knowledge of the flea-rat-human transmission cycle. But the general principle of delaying potentially exposed people from entering the community was sound. The Black Death itself and the subsequent outbreaks of plague that recurred across Europe for several centuries after 1348 was an event of such magnitude that no community health system could have responded to it effectively. The mortality rates in the initial pandemic were catastrophic, estimated at between a third and half of the European population over the period of the first outbreak. This scale of death was beyond anything that could be managed or mitigated by any available means, and the responses to it, medical, religious, social, and administrative, were uniformly inadequate to the scale of the event. What the plague responses do illustrate is the range of approaches that medieval communities had available when confronted with something entirely beyond their previous experience. They called on prayer and religious observance. They called on physicians who were largely helpless, being armed with a theoretical framework that had no purchase on the actual cause of the disease. They called on folk medicine, which similarly had no specific response to a disease that had never before been encountered in living memory. They fled when they could, which sometimes helped and sometimes spread the disease further. They isolated the sick, which helped for pneumonic plague, but less for the more common bubonic form. The aftermath of the plague, in communities that had lost enormous fractions of their populations, included changes in the social and economic organization of rural life that had indirect but real effects on health. Labor was scarcer, which gave surviving peasants more negotiating power. Wages rose, the standard of living fell. Many rural people improved somewhat in the decades after the initial pandemic. Better nutrition and less overcrowding reduced the background rate of various infections and probably contributed to the gradual rebuilding of population that occurred over the following century. Water was the fundamental health resource around which communities organized, and the quality and accessibility of water shaped health outcomes in ways that were observable even without understanding of waterborne disease. The relationship between water sources and illness was known empirically. Communities whose water came from springs or wells that were distant from animal pens and from the places where human waste accumulated were healthier than communities whose water was in closer contact with those sources of contamination. The positioning of wells in medieval villages was not random. Where communities had been established long enough to accumulate experience with the relationship between water source, location, and illness, there was a tendency to place wells uphill and upstream from the primary sources of contamination. This positioning was based on the same kind of accumulated observation that governed other folk health knowledge, not on understanding of the microbiological processes involved, but on the observable correlation between proximity to contamination and subsequent illness. Water for drinking was sometimes boiled, either intentionally as a health measure or incidentally as part of food preparation, and the brewing of ale and beer produced beverages that had been boiled as part of the process, killing pathogens that would have survived in untreated water. The widespread consumption of ale and beer in medieval communities, including by children, was not simply a matter of cultural preference for alcohol, but reflected a practical understanding, again empirical rather than theoretical, that these beverages were safer to drink than untreated water in many circumstances. The amount of water consumed for drinking was lower in medieval communities than in modern ones, partly because many fluid needs were met by fermented beverages and partly because the body adapts over time to lower fluid intake. But the quality of whatever water was consumed was a significant determinant of health, and communities that managed their water sources well had better outcomes from waterborne diseases than those that did not. The relationship between cold and illness was understood in medieval communities in ways that were partially accurate and partially not. Cold was associated with illness, which is true in the sense that respiratory infections spread more easily in winter when people are crowded indoors, and in the sense that cold stress reduces immune function. But the specific mechanism, respiratory virus transmission in closed spaces rather than cold itself, as the direct cause of illness, was not understood, and various beliefs about cold exposure as the direct cause of disease led to health practices that were sometimes overcautious and sometimes not cautious enough. The emphasis on keeping sick people warm, on avoiding drafts, on not letting convalescents go into the cold before they were ready was consistent with a basic understanding that cold stressed the body and that a body already working to recover from illness needed protection from additional stress. This was broadly reasonable. As a precautionary principle, even if the specific mechanism was misunderstood, woolen clothing, the primary textile available to most medieval peasants, has genuine thermal properties and is also somewhat resistant to moisture in ways that make it better at maintaining warmth in wet conditions than most plant fiber alternatives. The tradition of using woolen clothing, particularly in northern European climates, where cold and wet were significant health hazards, was both practical and culturally embedded in ways that reinforced each other. Communities in cold climates that had access to sheep and the knowledge of wool production had a genuine health advantage over those that did not, expressed in terms of the incidence of cold, related illness, and the severity of conditions whose outcomes were worsened by cold exposure. Sleep and rest were understood as essential to health in medieval thinking, which aligned with ancient Galenic medicine in identifying sleep as one of the 6 non-naturals, the external conditions that affected health and whose proper management was central to preventive medicine. The practical management of sleep in a peasant community was shaped by the constraints of the environment, the season, and the demands of agricultural work. The light regime of a pre-electric world was fundamentally different from what most modern people experience. In winter, the period of natural darkness extended from perhaps 4 or 5 in the afternoon to 7 or 8 in the morning, and while the household fire and whatever lamps were available provided some light for a portion of those hours, the cost of fuel and the limited light produced by rush lights and tallow candles meant that extended periods of darkness were genuinely dark. Studies of sleep in populations without artificial lighting have found that sleep patterns in these conditions tend to differ from modern patterns, with a first sleep period in the early evening hours followed by a period of wakefulness in the middle of the night, and then a second sleep period before dawn. This biphasic sleep pattern, which shows up in various historical sources as a matter of routine description rather than medical concern, appears to represent a natural human sleep pattern that was suppressed by artificial lighting rather than a sleep disorder. The woman at the beginning of this narration, lying awake in the middle of the night listening to the children, was in a sleep pattern that was entirely normal for her time and circumstances. The summer work schedule, which was constrained by daylight rather than by darkness, produced different patterns with longer waking hours and potentially shorter total sleep time during the peak agricultural periods. The extreme seasonality of agricultural labor in medieval northern Europe, with its periods of intense demand in spring planting and autumn harvest, and its relatively slower winter periods, created a natural cycle of work, stress, and recovery that, while not designed around health considerations, provided some degree of seasonal variation in the demands placed on the body. Dental health was one of the areas where medieval peasants suffered consistently and visibly, and the effects of poor dental health on general health are more significant than is sometimes appreciated. The medieval diet, which was high in coarse grains and low in refined sugar, produced a different pattern of dental disease than the diet of later periods. Dental wear from the grit in stone-ground flour which abraded the tooth surfaces was common and could progress to exposure of the dental pulp, causing severe pain and potential serious infection. Dental caries, the bacterial decay associated primarily with sugar consumption, was less common than in later periods precisely because refined sugar was scarce and expensive. The teeth visible in medieval skeletal remains often show extensive wear and periodontal disease, including bone loss around the roots from chronic infection, but relatively few cavities compared to post-medieval populations with access to more sugar. The extraction of painful teeth was the primary dental treatment available, and it was performed by a range of practitioners, including barber surgeons who also handled other minor surgical procedures, traveling specialists, who made circuits between markets and fairs, and in cases of necessity by anyone willing to attempt the procedure. The instruments used were forceps of various kinds, and the technique was essentially pulling the tooth out with mechanical force, which is both painful and, when done badly, liable to leave root fragments in the socket that could cause subsequent infection. The management of tooth pain before extraction, or in cases where extraction was not immediately possible, drew on the same plant pharmacopoeia used for other pain. Clove oil, which contains eugenol, a compound with genuine local anesthetic properties, was applied to painful teeth. Oil of cloves appears in various medieval remedy collections as a treatment for tooth pain, and its effectiveness in reducing pain is real enough that eugenol is still used in dental practice. Various other preparations, including thyme, which contains thymol with antiseptic properties, were also used. The care of eyes was another area with both significant disease burden and a specific body of practical knowledge. Eye infections, cataracts, and conditions now associated with nutritional deficiencies were common. The washing of infected eyes with herbal infusions, particularly those made from plants with antimicrobial properties, was a standard practice. Eyebright, whose name suggests its traditional association with eye conditions, was used extensively. Chamomile washes, which are anti-inflammatory, were applied to irritated and infected eyes. Rose water produced from rose petals was another standard eye wash. Night blindness caused by vitamin A deficiency was recognized as a condition associated with inadequate diet and was treated with preparations containing liver, which is rich in vitamin A. The traditional association between liver consumption and good eyesight is not coincidental. Communities that had regular access to liver, whether from domestic animals or from game, had lower rates of vitamin A deficiency and its ocular manifestations, and this relationship was observable even without knowledge of vitamin chemistry. The management of cataracts, which progress slowly and eventually produce complete blindness in the affected eye, involved no surgical treatment in most peasant communities because cataract couching, the procedure in which a sharp instrument is used to push the clouded lens out of the visual axis, required surgical skill and equipment that were not available to most rural practitioners. Couching was performed by itinerant oculists who traveled between communities offering the procedure with variable results, and it remained the primary intervention for cataracts throughout the medieval period and long afterward. The pig was arguably the most important single animal in the medieval peasant health economy, and its importance went beyond simple nutrition. The pig converted organic waste, including food scraps, kitchen refuse, and various agricultural byproducts, into protein and fat of a density and storability that had direct health implications. The autumn pig killing, which was a central event in the agricultural calendar of most peasant communities in Northern Europe, produced a reserve of preserved meat in the form of salt pork, bacon, lard, and various sausage preparations that sustained the household through the winter months when fresh food was scarce. The lard produced from the pig was not only a cooking fat, but a base for medicinal preparations. Fat-based preparations of medicinal plants, using lard as the carrier, were applied externally to skin conditions, muscle pains, and joint complaints. The fat provided a vehicle for carrying fat-soluble plant compounds through the skin and kept the affected area moist and warm, which facilitated the therapeutic effect. The pig's bladder, stomach, and intestines were used as containers and casings for food preservation, making use of every part of the animal in a system that left very little to waste. This thoroughness in use was both an economic necessity and, from a nutritional standpoint, potentially beneficial because organ meats that were otherwise less desirable contained nutritional content, particularly iron, zinc, and fat-soluble vitamins that supported health in ways that a diet of muscle meat alone would not. The relationship between animal keeping and disease was complicated. Animals in close proximity to human living quarters, which was the standard arrangement in many medieval farmsteads where the buyer and the house shared a roof or were directly adjacent, created conditions for zoonotic disease transmission and for the contamination of living spaces with animal waste. But animals also provided warmth, and the practical decision to house animals and people in close proximity in cold climates was made on a calculation that weighted warmth against contamination risk, and warmth sometimes won. The garden and the field together constituted the food system that was the foundation of health for most medieval peasants, and the management of that system across the seasons was a health management exercise as much as an economic one. The sequence of foods available through the year and the practices that modified and extended that sequence determined the nutritional landscape within which bodies worked and recovered from illness. Spring was the most nutritionally precarious season in northern European climates, coming after the winter depletion of stored foods and before the first crops were available. The period, sometimes called the Hungry Gap, in the months of March, April, and May, before the early vegetables and spring lambs and first cheeses of the new season were available, was when nutritional deficiencies were most acute and when the immune suppression that accompanied those deficiencies made people most vulnerable to infectious disease. The traditional practices that addressed the Hungry Gap included careful management of winter stores to ensure they lasted until spring supplies were available, the gathering of wild plants, including nettles, sorrel, watercress, dandelion leaves, and various other early emerging species whose nutritional content supplemented the depleted stores, and the keeping of hens that continued to lay through the spring, providing eggs that were a significant nutritional resource during this period. The preservation of food for winter was a major preoccupation of the agricultural year, and the methods used: salting, drying, smoking, fermenting, and storing in cool conditions. Each had their own effects on the nutritional content of what was preserved. Fermentation, in particular, used for the preservation of dairy products, as cheese, of vegetables as sauerkraut-like preparations, of grains as bread and ale, produced foods with probiotic content and with enhanced availability of certain nutrients compared to the raw ingredients. Whether medieval peasants understood the health implications of fermentation in any theoretical sense is uncertain, but the practices themselves were well established, and their contributions to health were real. The transmission of health knowledge within communities was continuous and embedded in the social fabric in ways that did not require formal instruction or institutional support. A child growing up in a medieval village absorbed health knowledge the way they absorbed everything else, through observation, through participation, through the stories and practical teachings of the adults around them, and through their own experience of illness and recovery. By the time a young woman was running her own household, she had already observed and assisted with the care of sick people, had been present at births and at deaths, had learned which plants were gathered from where and processed in which ways for which purposes, and had developed a practical sense of the range of normal and abnormal in the health of the bodies around her. This knowledge was not comprehensive by any standard, and there were large areas of uncertainty and ineffectiveness within it, but it was the result of many years of practical immersion in the management of health in her specific community and environment. The knowledge was also local in important ways. Plants available in one community might not be available in another. Water quality varied. The specific diseases that were prevalent in a community shaped the accumulated knowledge of that community in ways that made some knowledge highly specific to local conditions. A wise woman from a coastal community with knowledge of seaweed preparations and fish oils and the specific conditions common in maritime environments had different knowledge from one in an inland agricultural community, and neither set of knowledge transferred entirely to the other's context. This locality of knowledge was a strength in normal circumstances and a weakness when circumstances changed. Communities that faced new diseases for which their accumulated knowledge had no response, whether those were the new epidemics that periodically moved across Europe or conditions associated with environmental changes, were suddenly without resources and had to learn through the costly process of trial and error that had produced the knowledge they did have. Itinerant practitioners of various kinds moved through the countryside and supplemented the local knowledge, base with skills and materials that were not available within any single community. The barber surgeon was among the most common of these, offering bloodletting, tooth extraction, wound treatment, and various minor surgical procedures at markets and fairs, and in the households of those who could afford to pay for a visit. The barber surgeon's training was craft-based, acquired through apprenticeship to an established practitioner, and the quality of what was offered varied enormously with the skill and experience of the individual. Bloodletting, the removal of blood from a patient as a therapeutic measure, was among the most commonly offered services and one of the most persistently used treatments across the medieval period. From the perspective of modern understanding, bloodletting was generally not helpful and in severe cases was positively harmful, weakening an already compromised patient. But its persistence in practice reflected both the theoretical framework of humoral medicine, which provided a rationale for it, and the genuine difficulty of assessing outcomes in a medical context without controlled trials or systematic follow-up. Patients who recovered after bloodletting were attributed to the treatment. Patients who deteriorated after it had usually been very sick to begin with, and the deterioration was attributed to the severity of the illness rather than the treatment. The persistence of ineffective treatments in any era, including our own, is partly explained by this asymmetry in how outcomes are attributed, and it was as operative in medieval medicine as anywhere. What was valued and what genuinely had value was the presence of the practitioner, the attention given to the sick person, and the confidence communicated through the performance of treatment, regardless of the specific biological effects of the treatment itself. Children occupied a particular position in the medieval health system, both as the most vulnerable population and as the primary concern around which much of the practical health knowledge was organized. The range of childhood illnesses for which specific remedies existed in folk medicine is extensive and reflects the central importance of child survival to communities where birth rates were high and infant and child mortality was a constant concern. Teething, which is not an illness but which coincides with a period of vulnerability for other reasons, was a major preoccupation. Remedies for the pain of teething included the application of preparations to the gums, the provision of hard objects for the infant to chew on, and various herbal preparations intended to reduce the fever and fussiness that were associated with teething. Some of the specific plants used were chamomile and hops, both of which had genuine sedative and anti-inflammatory properties. And the observation that these helped was accurate, even if the mechanism was not understood. The respiratory infections that killed children in large numbers, the croup, the whooping cough, the pneumonias of winter were approached with steam inhalation, herbal chest rubs made with warming and aromatic plants, including mustard, thyme, and various other species, and with the provision of warm liquids. Steam inhalation, with aromatic plants added to the water, produced warm, humid air with some antimicrobial compounds from the plants, and while it could not cure a bacterial pneumonia, it could relieve the symptoms of upper respiratory irritation and potentially reduce the incidence of secondary infection. Diarrheal diseases in infants and young children were among the most acutely dangerous conditions because dehydration in small bodies proceeds rapidly and has serious consequences. The instinct to replace fluid lost through diarrhea was present in folk medicine in the form of the advice to give small amounts of fluid, frequently, and various preparations including boiled water with a small amount of honey or salt, which is functionally related to modern oral rehydration solutions, were used. The effectiveness of these preparations at preventing fatal dehydration in moderately sick children was real, though severe cases that required large volumes of fluid replacement quickly were beyond what oral rehydration could address. Moving through the agricultural year and attending to the health conditions associated with each season provides a useful way of understanding the rhythm of medieval health management. Spring brought the hungry. Gap, the gradual improvement in nutrition as fresh foods became available, and the respiratory infections that spread in the cramped indoor conditions of winter. Summer brought accidents from agricultural work, heat, related conditions during the most demanding labor periods, and the waterborne illnesses that spread more readily in warm conditions. Autumn brought the exhaustion of harvest work and the beginning of preparations for winter. Winter brought cold, darkness, respiratory illness, and the slow use of stored provisions. The summer harvest period, with its concentration of physical labor in the cutting of grain, the management of large work parties, and the race to bring crops in before weather changed, was a time of heightened injury risk. Cuts from scythes and sickles, falls from grain wagons, hernias from sustained heavy lifting, and foot and leg. Injuries from working in stubble were all hazards of harvest season, and the household management of these. Injuries used the materials on hand, which in summer were more varied than in winter, including fresh plants at their peak of available active compounds, the autumn slaughter of animals, the pig killing already mentioned, and also the culling of cattle and sheep. Before winter, when maintaining animals through the cold months was more costly than could be justified by the animal's productive capacity, provided concentrated access to organ meats with high nutritional density that supplemented the diet at a time when the body was building toward winter. The fat deposits of the autumn animals provided the lard and tallow that were used for cooking, for lamp fuel, and for medicinal preparations through the winter. The knowledge of dangerous plants was as important as the knowledge of therapeutic ones, and it was maintained with the same care. The distinction between a therapeutic dose and a toxic one was understood for many plants, and the specific warnings associated with particular species were part of the knowledge base that was transmitted through the same channels as the positive therapeutic information. Children were taught early about which plants not to touch or eat, and the list of dangerous species in temperate European environments is substantial. Hemlock, deadly nightshade, henbane, foxglove, monkshood, yew, and many others. The use of some of these dangerous plants at carefully managed doses for specific medical purposes was also part of the advanced knowledge held by experienced practitioners. Henbane, which contains scopolamine and atropine, was used as a sedative and pain reliever, and its use in this context appears in various medieval herbal sources. Foxglove, which contains cardiac glycosides that affect heart rhythm and whose excessive dose is fatal, was used in traditional medicine for various conditions. The gap between therapeutic and toxic doses for these plants is narrow, and the skill required to use them safely was real, which is why knowledge of them was concentrated in experienced practitioners rather than distributed through the general population. The association of some medicinal knowledge with danger meant that it was also associated with a kind of power. The wise woman who knew how to use foxglove or henbane safely possessed something genuinely valuable and also genuinely threatening if misused. And this duality reinforced both her status and the social ambivalence with which she was sometimes regarded. The boundary between what medieval communities understood as medicine and what they understood as magic or religion was not consistently drawn in the way that modern categories would suggest. The charm, a combination of spoken words and specific actions or materials, was a therapeutic tool that occupied a space between prayer and practical remedy and was used for a wide range of conditions. Charms were recorded in various manuscript sources alongside herbal recipes and dietary advice, treated as part of the same practical toolkit rather than as categorically different. The charm for stanching blood involved specific words spoken while applying a dressing. The charm for toothache involved a ritual action along with a plant application. The charm for curing a child's wasting illness involved visiting a specific place at a specific time and performing specific actions. Whether the efficacy of these practices rested entirely on psychological mechanisms or whether some of them included physical components whose therapeutic value was independent of the ritual framing is sometimes difficult to determine because the charm and the physical treatment were often combined and transmitted together. What is clear is that the framework of belief within which these practices operated was one in which illness had causes that included spiritual and supernatural dimensions alongside physical ones, and treatment, therefore, needed to address those dimensions as well as the physical symptoms. A treatment that addressed only the physical from the perspective of a sick person who understood their illness to have spiritual causes was therefore incomplete by definition, and the inclusion of the spiritual or magical element was part of what made the treatment feel adequate to the situation. Leeches occupied a small but persistent place in medieval wound and skin management, distinct from the general practice of bloodletting. Medicinal leeches were applied directly to bruises, to areas of local inflammation, and to various skin conditions, and they performed the localized removal of blood with a precision that was difficult to achieve with cutting instruments. The leech's saliva contains hirudin, a compound that prevents blood clotting, which means that a leech attachment produces prolonged local bleeding after the leech detaches, which was part of the therapeutic intention of reducing localized blood accumulation. The use of leeches for reducing hematomas, the localized blood accumulations that form after bruising, had genuine therapeutic value that is reflected in the fact that medicinal leeching has been revived in modern, specialized surgical contexts for exactly this purpose. The observation that leech application reduced swelling and improved outcomes in bruised tissue was empirically sound, and it was one of the traditional practices that survived the transition from folk medicine to formal medicine, partly because it worked reliably enough to maintain itself in the record. The collection of leeches from their natural habitats in ponds and slow-moving water was a specific practice, and communities with access to suitable leech habitats had this resource available. The trade in leeches was eventually significant enough to have effects on leech populations in Europe, particularly in the 19th century when formal medicine's appetite for leeches was substantial. But in the medieval period, the collection was for local use, and the populations were more abundant. The gradual accumulation of practical knowledge over the medieval centuries was not only a local village process. Knowledge moved through various channels, including the trading networks that connected communities, the movement of practitioners and pilgrims, the manuscript tradition of the monasteries, and eventually the printed books that began to disseminate written versions of both learned and folk medical knowledge more widely from the late 15th century onward. The printed herbals of the late medieval and early modern period, texts like the various editions of the herbal tradition that circulated in English, German, and other vernacular languages, represent an attempt to codify and transmit the plant knowledge that had previously existed primarily in oral and manuscript traditions. These texts drew on both ancient classical sources, primarily Dioscorides and the Galenic tradition, and on accumulated practical experience, producing a mixture of ancient theory and contemporary folk knowledge that was practically useful even where it was theoretically confused. The circulation of printed herbals made plant knowledge more accessible to literate households, which was a relatively small subset of the population in the early printing period but grew steadily over time. A household with access to a printed herbal had a reference that could be consulted when the usual living sources of knowledge were not available, and the existence of this reference reinforced and standardized some of the plant knowledge that had previously varied more between communities. The overall picture that emerges from examining how medieval peasants managed their health without access to modern medicine is one of genuine resourcefulness operating within real and significant constraints. The knowledge they had was imperfect, often wrong about mechanisms while being right about outcomes, but it was the product of long accumulated observation, and it was not nothing. The social systems within which that knowledge operated, the mutual support, the village networks, the family care, the access to monastic infirmaries when necessary provided a practical scaffolding that translated knowledge into action. The limitations were also real. Systemic infections that would now be treated with antibiotics killed people who would have survived with modern treatment. Nutritional deficiencies whose effects accumulated slowly over years reduced the general resilience of the population in ways that compounded every other health challenge. Childbirth claimed women who would have survived with modern obstetric care. Accidents that would now be managed with imaging and orthopedic surgery produced permanent disability or death from complications. The life expectancy numbers capture this reality in their cold, statistical way. The years that were lost to infections that were essentially untreatable, to complications of injuries that a modern emergency room would manage straightforwardly, to nutritional deficiencies that a varied modern diet prevents, were real losses felt in real communities by real people. The herbs and the prayers and the practical knowledge and the mutual care were not sufficient to prevent these losses, but they were not insignificant either. There is something that looks like competence in the way these communities managed what they could manage. The care was not random, it was organized around principles, empirically derived rather than theoretically grounded, that had enough validity to keep populations functioning through conditions that were objectively hard. The women who managed that care were skilled in ways their circumstances did not always allow to be recognized, and the knowledge they maintained was the accumulated experience of many generations working with the specific plants, animals, soils, and weather of specific places. That knowledge eventually fed into the formal medical tradition as well through the route of observed practice rather than theory. The plants that are now understood to contain pharmacologically active compounds were identified by traditional practitioners long before the chemistry was available to explain why they worked. The practices of wound cleaning, isolation of the sick, provision of fluids to the feverish, and rest for the recovering all reflect genuine insight into health management that was arrived at through observation rather than theory. What the tradition lacked, and what eventually made the transition to scientific medicine so significant when it came, was a reliable mechanism for distinguishing between what worked and what did not. In the absence of controlled trials, of systematic follow-up of outcomes, and of the conceptual tools to identify mechanisms, the effective and the ineffective coexisted in the same remedy collections and were transmitted together. The willow bark tea and the charm spoken over it were passed on as a unit, and separating the active component from the ritual context was not something the tradition had tools to do. The evening is coming on in the village again. The coals in the hearth are being covered to last through the night. The woman who was listening to the child cough in the dark has been busy all day with what she knows. There was a tea made from dried elderflower that she had put by in autumn. There was a piece of soft cloth placed on the child's chest, spread with a preparation she made from lard and dried herbs, thyme and hyssop in the late summer. There was broth kept warm all day and offered in small amounts. The child is still coughing. These things have not cured it because nothing she has does that, not for this kind of cough in winter. But the child is drinking. The child is not worse than yesterday. She will watch through the night as she has watched before, and in the morning she will do the same things again. She knows from experience that most children who cough this way in winter are better by the end of a week, and that the ones who are going to be worse will show it clearly, and that when they do, there are other things to try, and the monastery is not more than a day's walk. She's been doing this all her life, and the knowledge she is working from is all of that life and all of her mother's life and all the lives before that, distilled into what she does with her hands on a cold night when a child is sick and there is nothing else to call upon. It is imperfect knowledge working on an imperfect situation, and it is doing what it can. The coals hold their heat. The animals breathe in the next room. The village is quiet around all of it, dark and settled into the particular stillness of a winter night that has been going on for a very long time.